Top Med Talk.
Welcome to Top Med Talk. This piece has been supported by an unrestricted educational grant from bioMérieux.
My name's John Prowle. I'm a critical care physician and nephrologist from London, and I'm going to talk about perioperative AKI and in particular the recommendations of the ADQI 24 POKI 7 meeting that focused on this topic. So this meeting was conducted at what seems like a very long time ago before the coronavirus in Cambridge, and it was a collaborative group of perioperative physicians, anaesthetists, surgeons, and other healthcare professionals interested in this area. The meeting wouldn't have been possible without generous industry support. However, the industry had no input into the deliberations and the writing of our final report. Our consensus statement was published in Nature Reviews Nephrology earlier this year, a little delayed by the events of the last 18 months. And I urge you to look at this manuscript, which is open access, because I'm just going to give you a very brief overview today. So in this meeting, we sought to develop some consensus statements based on evidence synthesis and expert opinion about the definition and management of post-operative acute kidney injury, with a focus particularly on the non-cardiac surgical setting. This involved the development of a series of research questions, pre-conference identification of an evidence and literature base, and then a serial re-evaluation of our questions as we developed appropriate answers within work groups and plenary sessions using a modified Delphi methodology and employing the grade framework to describe our findings. So in our deliberations, we identified the following areas: the epidemiology and pathophysiology of perioperative AKI, what definition should we use, prevention strategies, ways in which we might prognosticate and treat patients who have developed acute kidney injury, and the very important aspect of outcomes after perioperative AKI. Why are we interested in perioperative AKI in particular? Well, we know that surgery has low short-term mortality, and therefore mortality itself is not a good outcome assessment for the way in which we're trying to improve surgical outcomes, but perioperative complications associated with both short and long-term adverse outcomes. And so from the point of view of perioperative medicine in general, we need better research and clinical endpoints that are associated with long-term and meaningful patient outcomes, because the burden of surgery persists beyond the perioperative period, and we should therefore be interested in the long-term consequences of the short-term harm that you might experience as one undergoes surgery. We think AKI is perhaps a uniquely quantifiable complication of key physiological and clinical relevance in this population. It's of great meaning in its own right because it is connected to the outcome of chronic kidney disease, which is a very potent risk factor for a multitude of adverse long-term outcomes. But it also signals physiological instability and is a great canary in the coal mine for both short and long-term mischief in our patients who've undergone major surgery. And this has been encapsulated in various vignettes and cartoons that were popularised, such as this one from the RCOA, where a patient undergoes surgery, has a number of surgical and non-surgical problems, but undergoes a worsening of kidney impairment during his surgery. And this has significant impact for his long-term health, even though perhaps the kidneys weren't at the forefront of his healthcare needs at the beginning. So what do we say about the epidemiology and pathophysiology of AKI? Well, it's very important to recognise in any setting that acute kidney injury is a clinical syndrome, not a disease. In the majority of cases of perioperative AKI are multifactorial, but that does actually make it important because it's a potential relevance to a wide variety of patients. The instance will obviously vary with the characteristics and urgency of surgery, and there are a number of surgical settings where we have less knowledge about AKI. And there's obviously different flavours of AKI diagnosis in terms of oliguria or defined by serum creatinine. It certainly seems to be true that severe oliguria is particularly significant. However, transient periods of oliguria after surgery are of a less certain significance. This is just some of my previous data in a meta-analysis where there is about 13% incidence overall of AKI in major abdominal surgery, but you can see this varies very much between different surgical settings and patient characteristics. It's important to note that most studies are focused on AKI occurring immediately after surgery, and there is very little evidence available regarding how AKI progresses after the initial period, which we have termed the period of acute kidney disease rather than acute kidney injury. However, the risk factors for perioperative acute kidney injury itself are relatively well described, including older age, prior chronic kidney disease, and diabetes, cardiovascular disease, and a variety of other comorbidities, as well as exposure to a variety of other potentially nephrotoxic medications. So moving on to definitions, and this draws on previous work from the Step Surgery Initiative and other sources. Really, the KDIGO definitions of AKI are what are being used. They have a lot of evidence base behind them, and they should be what we continue to use in the absence of something better to refine these, which at the moment does not exist. And the time window on the basis of alignment with the KDIGO definitions would be within 7 days of the operative insult. And it's very important to note that we do need to detect acute kidney injury after surgery in order to act on it. And so a very important part of our assessment of patients is their risk stratification, not just for preventative measures, but actually for monitoring. And the way in which we assess patients, we've currently begun to define as what we call a kidney health assessment. And a kidney health assessment is a way of assessing somebody's current kidney health, their prognosis for changes in their kidney health, and making actions accordingly. And this can be done at a variety of stages and has different characteristics depending on the stage it's given. But it involves identification of a high-risk population, understanding what acute exposures they're going to have, considering the risks of medication, of contrast exposure, of surgery itself and other acute illnesses, and potentially what responses one would make in terms of adjustment of medication, minimizing other exposures, monitoring and critically communication with both other healthcare professionals and the patient themselves. This more broad concept of the kidney health assessment we've refined and applied to the perioperative setting at various stages. Just in terms of what happens after the first 7 days, as I alluded to earlier, there is this term acute kidney disease, which it refers to the persistence of renal dysfunction after acute kidney injury, and is sort of essentially fills the gap before one could formally define chronic kidney disease. But obviously, within this post-operative acute kidney disease setting, there can be a number of different patient trajectories that may occur. Some of these may be related to a progression or recurrence of initial perioperative acute kidney injury, but there may also be patients who develop de novo late acute kidney injury still within their surgical episode. And it's difficult to know how to define these patients, and that's certainly a research priority. What should we do about patients who have identified at higher risk? Well, this really involves an understanding of the epidemiology of perioperative acute kidney injury, which will be related to preoperative factors, intraoperative factors, and postoperative factors. And these may affect both blood flow and renal demand, leading to AKI, potentially acute kidney disease or chronic kidney disease down the line. And of course, we are very focused in terms of risk prevention in identifying potential nephrotoxin exposures. And these are essentially the usual suspects. But really, we need to target and think in a rational fashion about the use of these and the risk balance in patients who have differing risks of acute kidney injury. So we recommend really that there should be a considered approach to medication based on risk. We do recognise that there's probably an evolving literature about the use of ACE inhibitors, but they are certainly associated with biochemical acute kidney injury after surgery. And we're talking about minimising the risk of perioperative hypotension, which in itself is obviously a risk factor for acute kidney injury. Again, when we're talking about perhaps two-edged swords, perioperative use of ACE inhibitors is an interesting one because, of course, their analgesic benefits may be substantial in certain settings. And so, again, a risk-benefit profile is essential when we're considering these medications in patients more at risk of acute kidney injury. What about intraoperative strategies? And I'm going to breeze through some of these in terms of time, but really we need to have a modern approach to fluid balance management, not overly restrictive, but not overly liberal. And this may be aided by the use of goal-directed hemodynamic therapy in order to guide our fluid resuscitative techniques. And of course, in patients who are non-fluid responsive, who have persistent hypotension, we may need to use vasopressors to target mean arterial blood pressure in order to ensure renal perfusion, and we, I think, should not be afraid to do that. If we are using fluids, they should be balanced solutions. And there still is the question, and this goes back to the preoperative goal-directed therapy, about the safety of various forms of colloid in non-septic elective surgical patients. And there's probably evolving evidence in this area that we need to continue to monitor. What about early post-operative strategies? Well, again, this is all directed to maintenance of adequate organ perfusion, and that may involve monitoring of patient in a high dependency area where appropriate hemodynamic interventions can be given. The avoidance of hypoglycemia is probably important in the perioperative setting, more so than in other aspects of ICU care, particularly in certain forms of surgery, and would form a part of a good standard of care. It's important, obviously, that if we have revised a patient's medication, that we continue to look at those changes and appropriately restart important medications for their long-term health when they have recovered. What about enhanced recovery after surgery? This is a very important innovation in terms of improving surgical outcomes, but ERAS protocols do involve interventions such as relatively fluid restrictive techniques and the use of non-steroidals to spare opiate analgesia and promote early mobilization. And some of these may not be entirely compatible with our goals in terms of prevention of acute kidney injury. And so again, it's in terms of balancing risks and benefits of all the interventions we're giving patients in terms of their perioperative pathway if they are identified as a particular risk of acute kidney injury. What about patients who develop acute kidney injury? Well, again, this involves applying consensus-based interventions for acute kidney injury as tailored to the surgical setting. And largely this we found was a recapitulation of existing recommendations in terms of the institution of renal replacement therapy and identifying and treating the underlying causes of AKI. There is further research work to be given into understanding different phenotypes of AKI and understanding whether treatments can be tailored to specific causes. Finally, outcomes in patients with perioperative AKI or AKD. The particular importance of the assessment of outcomes is because we want to detect patients with new or worsening chronic kidney disease, which is associated with increased long-term morbidity and mortality, and has good evidence-based treatment strategies behind it. And how do we go about doing this? Well, again, we tailor our kidney health assessment to the patient's status in order to determine what pathway of care they need. So this just emphasizes that acute kidney injury can have effect on the kidney and in severe cases may require renal replacement therapy, but will also have an effect on a variety of other organ functions. And this can incur ongoing risks of cardiovascular problems or indeed predisposition to infection. Similarly, chronic kidney disease, if it's occurred, also has organ crosstalk with other organ systems and increases the risk of adverse outcomes, not just related to the kidney. And so we're seeking to intervene in this process and mitigate the long-term effects of acute kidney injury. But this has to be tailored to the severity of acute kidney injury. Broadly, what we're saying is the more severe and the longer duration of acute kidney injury, the less the renal recovery, the earlier monitoring you need, and the more likely it is need to be with nephrology-based care providers. But perioperative physicians, primary care physicians, and other healthcare professionals involved with the patients need to be vigilant in these less severe cases for the late development of CKD and other adverse consequences, because nephrologists do not have the resources to follow up all the patients. Again, as I emphasized, we have this kidney health assessment. This is the preoperative kidney health assessment, which involves assessment of a patient's history, background, and optionally some additional investigations to make an integrated assessment and develop a specific care plan. But we can extend this concept to the post-operative setting if post-operative AKI occurs, and into the follow-up setting. And it's really the same process of clinical assessment, optional additional investigations, integrated assessment of outcomes and risks, and then developing a tailored treatment plan. With that, I'll conclude by thanking all of the collaborators in this important meeting. It was a very, very productive, multidisciplinary exercise. Thank you very much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.